Thanks, everyone. And thanks to all the presenters, because I'm really inspired by the work that you've done. And we've come a long way in terms of actually doing proper co-design with patients and providers. So kudos to everyone. I think when Walter and the team invited me to join, I think there were a couple of other factors as well. So one, we did not approach this starting from a condition-specific basis, but really looked at the overall UHN population, and largely that's across the Greater Toronto area. And then the other pieces that we just to highlight in terms of the learnings that we can share is one, we've been at this for about 6 years now. So we have a little more data, I think, than some of the other teams around, what kinds of impact we're making. And then the last is as part of some of the work from a grant for CIHR, we are part of some learnings where we're looking at some common metrics and methodology on how to look at some metrics for integrated care programs across the country. So we've partnered with Alberta as well to look at expanding the work, what we've learned and what we can learn from them. So hoping to bring that back in future state. So just to set the context here is when we started down the path of integrated care at UHN, we knew we needed to start somewhere. And so we did start in surgery as a bit of a test of change and to evaluate how we would approach an integrated kind of model. And then very quickly, the plan was really expand across to all kind of groups across UHN. So really the idea is that any person coming to UHN would get an integrated care experience. Of course, that experience would look different depending on what kinds of support and the level of intensity they needed. But that would be phase 2. And we are now in at phase 3, where really are able to better take a look at population-based approaches. We started really in earnest around looking particularly at older adults. And that is really where much more of our efforts have focused on really being in the community, helping to prevent and support health promotion, and really looking at that whole person approach to overall well-being. So not just kind of a clinical or a kind of traditional health system focus. And so we're really at the phase 3 point right now. In terms of the experience that we're looking at, it's not dissimilar, I'm sure, to what many of you have heard of. The experience that we really wanted, that we heard from patients they really wanted care coordination. So no matter what kind of approach we're taking, someone always has one consistent care team with a single point of contact that they can reach out to. And so that's been really critical to build up one collective team. How do you actually work together? Do you get to see each other? Do you get to be doing the rounds? How do you provide bi-directional feedback and availability? The next is really around continuity of care, so having one story to be able to tell, and that really includes having a shared digital record. Most of that, I would say, for the patient, it came across as a shared digital record but it really was done with a lot of manual, we kind of call it the human middleware in the different transition points. And so happy to say that we're actually in the midst of creating that solution now for one shared digital record where not only those within UHN, but our various partners in home and community will also be able to have read and write access. And then the next will be is having the timely and accessible. So, really having a number to call where someone can speak to somebody has been really critical and has really been a really great lifeline for patients, but also their caregivers. And then the last one is making sure that the care can be customizable to the needs. And really core to that, the how of what we focus on that for is having one integrated fund. So slightly different than what some of the bundles of funding might work on. We look at the path, we look at the kind of the needs together, and we really identify, where do we spend the dollars? So it's not necessarily, I'm Melissa, and I'm going to spend, $200 on Melissa, but we're really able to adjust working with our different care partners. I am going to focus, because we have the most data, on the pathways where I think a lot of the work that we have heard about to date and the great work that we've heard about on this call is really looking at from a community lens, starting in community potentially. A lot of what I'm going to speak to, because I think it shows the clearest picture of the how for us, is that we have a much higher kind of acute care component. So these are where individuals might need to have much more connection back to a hospital and making sure that we have that timely access, as people get back out into the home as well. So I just wanted to set that context that we are focusing a lot more on increasing like higher acuity of care as well in these pathways. And so key to that work is really, the set of collective commitments that we developed with patients as well as our care providers in the organization. And so really, what does it look like when we address those care experiences? It means that you always have somebody to reach a person at all times, 24/7. If a patient or a care provider is reaching out to request clinical advice, we are responding within or under 30 minutes. And the other part would be, the other pieces would be having very clear action plans. So always making sure that there are escalation paths, if there are standing orders, medical directives, that somebody always has reach to somebody if within a hospital if required, and other partners as required. So that's been really key for us too. And then having direct care or admission, so not via emergency wherever possible. So that might be having direct outpatient clinic appointments, or perhaps it is us getting, somebody from a home care team to the individual's house, like kind of within the same day. And then the last two are really, really ensuring, that there are clear health equity to support, that we have clear mechanisms, that, we're not relying maybe just on digital or remote when that might not be the case for everyone, and that there's continuous quality improvement with all of our partners. I'll go to the next slide. I'm not going to spend a ton of time on these next few slides, but really just to draw the concept of when we look at this experience, what's key is one of our huge learnings that we could never do this work without is how do you go about creating that one care team? And if you look above the top, kind of a traditional transition out from hospital, you might have your hospital team on the right side at the top with like own separate funds. And then you really start to engage maybe a hospital care coordinator at the time of the point of discharge, right? Those conversations earnestly begin. You've got you're introducing a separate contact, and then back out into, once you're back at home, you may have a different coordinator and then multiple providers that you're having to coordinate, which makes it pretty challenging for the individual and their loved ones. And then below would be all the separate below is also a separate fund. So home care funds that you're operating under. If you look below, this is really where the approach we like to take, regardless of, where the transition is coming from. But in this case, it would be having what we call of as an integrated care lead identified right up front. So at the earliest point of a hospital admission, we're already looking at what is the expected length of stay and what are those barriers, and they're introduced right off the bat to the individual and their families. And then they're involved throughout the whole stay. So if we need or have difficulties with certain equipment, we're starting that planning right up front and getting it ready. So by the time we get to the expected discharge date, we are able to have a plan already in place, and that we've collaborated with whichever partners we need to along the way. And that person remains with this person all the way at the end, the recovery at home. The IC lead remains with that person until they are well. Generally, we have up to 90 days. If we're really seeing that there's a risk, then, we may look at extending it. But that's really, it's one record, one number to call, one team that we're following. And I'll go to the next one just to highlight our ability to look at creating system capacity, because of course, the patient experience was our first and foremost, but really to sustain this, we really had to look at how are we actually going to create and do more with what we have in the system today. So at the top, what you'll see is typically what we would see, right? You'd have somebody maybe admitted into hospital. That's the first event. They may, they'll stay in event one. Maybe you come back and there's an event two and you're here for another period of time, and then a third perhaps. And so you can see how that kind of time and the number of difference of people that you might be connecting with. What we're really looking at doing is when we work with one team with our number of providers, we're looking at that first event up front, like can we reduce that initial length of stay earlier? And because we're linking and following an individual over a period of time, either can we avoid any sort of return ED visit or readmission, or if it's completely necessary, can we make sure it's happening sooner? So that if they do have to be in hospital, that it is a shorter period of time because we've caught it sooner. So that's the concept that, in terms of showing how we're looking at creating system capacity, which is really critical to our sustainability. That's just on the right side is just to share, what the trajectory looked like for us over the past 6 years. We started slower. We, navigated the pandemic, not without many bumps and bruises. But what we then did is really, over the past couple of years, really expanded quite quickly. So as an example, last year we went live in 15 different departments across the organization. And so that has been really key to one, the sustainability of numbers that we're seeing, the consistency, and the training of the different care partners that we're working with so that they're trained in the same way. So what we know of in the hospital, also they know of in the community and vice versa. And so our impact to date, I'm super proud of this, as I'm sure many of the other presenters have seen. Our net promoter score is about a positive 79. Regularly we have 90+% patients rating the program at a 4 or higher out of 5. The number of bed days saved has been quite significant. So this is the estimated impact for about 4,000 patients on an annual basis. We are seeing our target was in the first year is to have 1 day length of stay for every individual involved in the program. And so we are seeing at about a 1.3 average, and in some cases it's higher. We're up to 2 to 3 days saved per individual. And we are seeing definitely decreases in ED revisits and readmissions. And so you'll see that, our initial target was at least a 5% decrease in various pathways. In some cases, we are seeing a relative reduction up to 43% for revisits. And readmissions, in some cases, we're seeing up to 25. It's of course not consistent across the board, but we are seeing that. And then I know we have our colleagues from IDS here on the call as well. But I think the other part that we've started to look at is what is the impact of this work, not only at UHN, but also across the region. And so we are seeing numbers where often, because of the trust and the relationship that has been built up, sometimes patients would like to come back to be seen at UHN. And so what we are evaluating and seeing is that that's actually having an increase across the region in that while people may be returning back to UHN slightly higher, it's actually decreasing the capacity for other organizations across the province as well. And so I think just my last one, and I won't spend a lot of time, and I know there was a comment about text being really small. So apologies for that here. It's certainly not critical to look at all the fine point details here. But I think what we wanted to highlight is that when, we're all looking at the quintuple aim, what really is the difference for the how and what people see on the ground on a day-to-day basis. And so if we look at the patient experience, it may mean that, somebody has left the hospital and they're experiencing some complications or some concerns. We are able to get someone there, like they're able to call the line. There's always a nurse on call to be able to clinically assess the individual. And in many cases, we're able to get a home visit within the same day, sometimes within the hour. And so those kinds of things really alleviate and really allow people to go back and feel safe in the comfort of their own home and know that they can be connected back into hospital if required. The other is around patient satisfaction, and I see you, Kaylee, coming up. Time to cut me off here. So I think the other pieces I'll just quickly highlight is that we are seeing that from a provider satisfaction is having that link back to their colleagues has been really critical for them to feel like they can best support the patient at home. So really having a better understanding of the patient, a check-in, is this normal to be recovering at home, has really created not only satisfaction that people can close things off while they're in the home, but also a confidence that they're being supported by a broader team. And then I won't spend too much time on the others, but we really are looking at shifting care away from hospital then into the home. And what we've heard from, let's say, our home care providers and community paramedicine in this case, they've really benefited from the shadowing and learning on the ground with our hospital teams and vice versa. And so they're taking on more of what would have traditionally been able to be done in hospital, and so seeing lots of value from that.